I apologize. Okay. Welcome everyone to New Mexico Department of Health Facilities and the Los Angeles Community Program Governing Board. It seems like we have a quorum here, so I will call this meeting to order. Today, Thursday, October 17th, the time is 10 a.m. We will first begin by a roll call, and we will start in this corner over here.
George Morgan.
Jose Garola, New Mexico Rehab Hospital Administrator.
Shauna Hartley, Turquoise Lodge Hospital.
Tammy Alucard, Los Lunas Community Program.
Donna Deason, New Mexico State Veteran Zone.
Todd Winder, Fort Berry Medical Center.
Peggy White, Fort Berry Medical Center.
Dr. Avinash Shashrekar, Deputy Secretary.
Eric Chenier, Acting Deputy Secretary.
Melinda.
Melinda Walensky, Assistant General Counsel, Office General Counsel.
Charles Jaramillo, CFO.
Francis Tweed, NMDOH Hospital Administrator.
Michelle Fields, Medical Staff Office. Susie Archuleta, Nursing Home Administrator, NMDHI.
Roberta Mijo, Administrative Services Division.
I think that's it. I just want to confirm once again with Jet that we're going to be taking accurate notes for minutes that will be published in the near future. With that, did everyone get an agenda for the day?
Yes.
Yes? Is there a motion to approve this agenda?
Second.
Great. If any points of discussion? I see no hands for discussion. All that move in approving the agenda, say aye.
Aye.
Aye. Nays? There's no nays. Okay, we'll move on to approval of the minutes of our previous meeting. And those were published and sent to you all as well. Does everybody have a copy of the previous minutes from the meeting dated July 18th, 2019?
In your email.
Okay. Is there an approval to approve the minutes of the previous meeting dated July 18th?
Motion.
Do I see a second?
Second.
Is there any discussion necessary? I will once again add that we will have more complete minutes for this coming meeting today, October 17th, as we have accurate but sparse minutes from the previous meeting of July 18th, right? Yes. Correct? Yeah, that's correct. Okay. Is all those in favor to approve the minutes as submitted to you all? Say aye.
Aye.
Nays? Any nays? Okay, the approval of the minutes of the previous meeting are accepted. We will move on to the bulk of our business reports and Office of the Secretary report. Today, I don't have much to talk about other than welcoming Eric as our acting deputy secretary. So from here on out, Eric and I will both be co-chairing these meetings, if he agrees.
Yes.
If he agrees. I think we will have the benefit, and this, looking back historically, I think we'll have a benefit of having a clinical medical doctor such as myself and somebody with Eric's enormous skill set that I can barely even scratch the surface of budgeting and finance. And so I think with both of us, we will be able to move into this new era well. With that, I think we'll begin with the facility administrator's reports. There's an order here. Is this the last time I just bungled this because the order was incorrect? Is this the correct order? Was Fort Berry going first? Because it's how you loaded it up, sir, right? Okay, so we will begin with this order, beginning with Fort Berry Medical Center and Administrator Winder. Okay.
This is the Governing Board of Administrators report for Fort Berry Medical Center for the first quarter of fiscal year 2020. First of all, we note our smaller up there than it is here. Our mission, vision, and values. Our mission statement is to serve the community by providing long-term care and rehabilitation carefully, consistently, continuously, and compassionately. Our vision is to pioneer a new kind of care center where people want to live and work. Our values include compassion, continuous improvement, integrity, creativity, and teamwork. Fort Bragg Medical Center is a 200 licensed and certified bed facility, providing services in skilled rehab and extended care. We have 70 beds. In our dementia care unit, we have 90 beds, and our veterans unit is 40 beds. As mentioned, we are licensed and certified for 200 beds, serving the people of New Mexico in services of rehab, skilled nursing, and long-term care. Facility residents include youth, elders, and veterans with healthcare needs who can no longer care for themselves. Within the campus of Fort Bragg Medical Center is the Fort Bragg State Veterans Home. This is a 40-bed unit dedicated to honorably discharged veterans, their spouses, and Gold Star parents. Currently, just over 16% of our resident population are under the age of 65. 37% are between 65 and 84, and 46% are over the age of 85. Currently, 48.6% have a psychiatric diagnosis, with 0% of the population having intellectual or developmental disabilities. This slide depicts some of our services we offer. As mentioned, our clinical services include skilled nursing, long-term care, post-acute care, and palliative care. In the areas of therapy, we have on-site physical, occupational, and speech-language pathology, and also respiratory. Dietary services, special diets with a dietitian and a nutritionist on site. Social services handle our care coordination, mental health and resident advocacy. Recreational therapy, do one-on-ones, group social, our religion and worship services, any special interest, and our community involvement for our residents. Health information, of course, we have the electronic health record and our MDS that we all have to do. Business office offering services in billing and benefit qualification. On-site medical, physicians and physicians extenders. On-site medical also includes our laboratory, pharmacy, radiology, and podiatry. We also offer behavioral health with on-site psychiatrists and on-site psychologists. And we have specialty support in dialysis services for our residents. Over the last quarter, our occupancy rate has averaged, our staffed occupancy is 88.87%, and our licensed occupancy is at 63.55%. This is the first time in the last 10 quarters that our staff capacity has been below 100%, which means that FBNC expects to be able to increase our average census if acuity continues at its current level.
Todd, can I stop you for 1 second? I just got an email from Dr. Massaro. Is the phone active? Is he on the line?
Caller on the line.
Okay, so it's probably just I guess he's online. Please go ahead, Administrator.
Our utilization shows an upward trend during the first quarter, which is a reflection of our increased staffing capacity. As our staffing holds constant, we expect this trend upward in utilization to continue. Our average daily census shown there by each unit, as well as our patient days in each unit. Our total patient days were 1,862 on the low NIF, 1,642 on the high NIF, and skilled 1,685 each month respectively. This is our level of care census, indicating here that our low NIF days are our highest utilization, then our high NIF days, and our skilled nursing days. Once again, the increase in the average census is shown in the area of our low NIF and high NIF residents. This NIF census fluctuates significantly from month to month. With the new PDPM reimbursement system, we expect this level of care to stabilize as qualifications for this level of care are now less dictated by therapy and looks more at the resident overall when determining state benefits. During the quarter, FDMC had 21 admissions, resulting in an overall census change of +4. People served in July, we had 136, in August 137, and in September 132. This slide shows our hours per patient day by service provision. We averaged for the quarter of 4.46. This is compared to a scheduled HP hours per patient day of 4.6. The difference in scheduled and work is staff absenteeism. Our next area shows some of our finance indicators. For the first quarter, billings totaled 4.9 million. Of that total, 153,000 were indigent and approximately 474,000 accounted for the contractual allowances. Next slide.
That's not the next one. Finance.
So that's it, I'm sorry. FAMC collections for the quarter have been very good, with receipts totaling 5.2 million or 105.5% of billings. These collections, we know these collections are high in spite of some significant past due payments from our MCOs, which as of the end of August totaled over $700,000. Our accounts receivable are at 12.253 million, with 9.1 million being older than 90 days. Including our number of days from billed to collected is approximately 49 days. In the area of licensure and certification, currently all annual surveys have been completed and all plans of corrections have been submitted and approved. FDMC continues to monitor those areas that included findings to ensure ongoing compliance. As noted, CMS has yet to revisit the facility in person, but has requested all backup documentation regarding the findings. Because all findings were of minor scope and severity, backup documentation may be all that is required. This is our ICIP project list for the next 3 years. We're moving forward as scheduled. Work is currently in progress on the fire suppression and the ADA access. We project our projects completed include our IWA stations and our resident outdoor living environment. The other 2020 projects have not been started yet, but will be within the next 60 to 90 days.
Could you give us this is Dr. Utricker, could you give us a little bit more information about the water source infrastructure?
That is,
Is that, and George Morgan may be able to, is that the spring well and the spring boxes that need?
Yes.
that will change everything.
So the water infrastructure, we actually had a DOE, a declaration of emergency on the water source, and that was working with General Services Department and the National Cemetery there. To date, we're able to manage the capacity that's required to support the cemetery. We have a preliminary engineering study that's been provided in draft form. So we're continuing to monitor our springs, the volume and the volume of the water that's coming from the springs. Right now, we're looking at roughly around 70 gallons per minute from the springs. And again, that's preliminary. We've installed flow meters throughout the piping system, and the work continues. Our contract for the engineering study as a whole will be signed by this Friday, and we'll kick that off sometime next week.
Okay, thank you.
Next slide is some of our quality performance indicators. We use the indicators that come off the CMS website that is published on Nursing Home Compare. We do have some areas of improvement there. We are over the state national averages with patients. These are our long stay measures, this first slide. those patients reporting moderate to severe pain. Also on the residents of high-risk resident pressure scores. Percentage of residents whose need for help with daily activities has increased, as well as percentage of residents who received an antipsychotic medication. So those are 4 of our focus areas based on our quality indicators. Interestingly enough, I believe within the next month or so, CMS will be dropping their quality measure in regards to pain. That will no longer be one of their measures, as well as the ones with residents with increased needs with ADLs. This next slide shows some of the short-term measures. Again, the moderate to severe pain is also one that was demonstrated there, and the percentage of resident pressure ulcers that are new or worsening was also high this last quarter. Our quality and performance initiatives include addressing the reported pain by both short and long stay residents, new or worsening ulcers on short stay residents, the increase in ADL assistance, urinary tract infections, and the antipsychotic medication utilization. This slide indicates our patient satisfaction on the family side of the equation. We utilize the Abacus Quality Management System for measuring family and resident satisfaction levels. As illustrated on the next 2 slides, focus areas for the measures of satisfaction include there's an overall rating, a likelihood to recommend, an endorsement score, and what the endorsement score is the difference between those rated extremely likely and unlikely to recommend. And then it also measures some quality of life areas, quality of care, and quality of service. For the family satisfaction this past quarter, our overall rating was 98.2%. Likely to recommend was 98.2. The endorsement score was 33.3. We had a score of 89.3 in quality of life, a score of 87.1 in quality of care, and a score of 92.1 in quality of service. 2 areas that are focus areas. In family satisfaction was the area of choices and also the area of staffing. The way we select which ones we concentrate on is any indicators that fall below the 80% level. And those 2 areas did this past quarter. This next slide is the same questions, the same measures, but for our residents. The overall satisfaction among residents was 81.1. Likelihood to recommend was 78.4. The endorsement score was 2.7. Quality of life was 91.7. Quality of care was 77.4. Quality of service was 89.0. The areas that flagged with our patient satisfaction, once again, was in staffing and comfort. Those are our satisfaction initiatives for the areas that quarter over quarter indicated satisfaction scores below 80. Currently, those areas include choices, staffing, and comfort. The challenge with these initiatives are that they're not really tangible and or may be difficult to reach higher scores due to the nature in which each resident or family member perceives the measure. Also, the satisfaction measures may be influenced by outside influences that the facility is unable to control.
Do you have any idea of what the complaint is on the staffing? Like, what's the general issue?
That there's not enough.
Just not enough? It's not quality or anything else like that?
Just not enough. And I think a lot of our patients and families have that because our staff has that safety and they verbalize that to our families and our residents.
Could you explain what endorsement means?
Endorsement is the difference between the number of people that rated it extremely likely to recommend and not likely to recommend.
Okay.
Employee satisfaction, I'm in the process of getting that together. There is a module now available within Abacus where we can do satisfaction surveys with employees. So hopefully by next quarter, we'll have some ratings from our staff as well. In the area of human resources, Fort Bend Medical Center currently has an overall staffing vacancy rate of 14.56%. This represents average vacancy of 15.9% in direct care and 13.0% in indirect care staff. Over the quarter, the vacancy rate has been moving down, with vacancy levels better than they have been in the last 3 years. It's been noted that from the beginning to the end of the quarter, the budgeted FTEs dropped by 2. We are reviewing that to see why that occurred, or if we just got incorrect information on the number of FTEs we have. Because historically, we have been at 315. And our most recent schedule or report showed 313, so we're looking to see what happened there. That's where it's at. Also under human resources, I apologize for not having numbers for workers' compensation. I wasn't able to get that information, but I think we're about at 3 on workers' compensation. Also, our staff on FMLA is average 3.6, and that has gone down from the previous quarter. During the quarter, we had 28 hires and 13 terminations. The average turnover rate is 1.8, which is a significant improvement over the previous quarter.
Hey, Todd.
Yes.
Real quick, not question, but comment on workers' compensation. If any of you ever need any information on that, please reach out to Trevor Edwards, and Trevor can work with R&B and get you what you need.
Thank you.
Yep.
The overtime at Fort Bend Medical Center continues to be a challenge area, even with our increased staff numbers. The overtime is average around 8.91% for the quarter. And during the quarter, significant comp time was paid out to staff retiring, and this inflated the overtime level for the quarter. And currently, contract staff account for an average of 2% of our clocked overtime hours. Our needs and challenges, licensed nursing, though it's improving, still continues to be a challenge for us. This affects the acceptance of higher acuity residents as we have vacancies in our licensed nurses. We also have been down 1 therapist for quite a while. Our dietary staff is our highest area of turnover and currently is our highest area of vacancy. Another challenge is our pending regulatory changes with the education and competency provision and tracking that goes into effect next month on the 28th. There will also be some changes in programs with the trauma-informed care and behavioral health requirements, which also go into effect on the 28th of November. A challenge remains with our MCOs, a contract not being followed. I know they're in negotiations back and forth. As I mentioned before, the one contract accounts for $771,000 as of August 31st. That we're trying to get ironed out. I know Roberta's been trying to help us with that. And then another challenge we have is with our EHR, getting that fully utilizing the power of our point-click care system. Our community presence, we participate with Western New Mexico University School of Nursing on their advisory committee. We also participate on the Grant County Emergency Preparedness Committee. In fact, our safety officer is the chairman of that committee currently. A community dialogue we participated in. That's with our Silver City School District and our Chamber of Commerce are meeting with community leaders to determine what focuses to implement within the school district and the curriculum for the students. And then we also participate in the HMS Stepping Up project, which is a behavioral health intervention assertive community treatment team. And that's been going on for a few months, and we have participated with that as well. Some of our successes. Our licensed nurse recruitment, our vacancy there is lower than it has been for a few years, but we still need more. Onboarding Peggy White, our new assistant administrator. She's been a welcome addition. Our organizational structure, realigning departments by function under assigned leadership. Our goals are to continue enhancing our WAPI program, to complete our strategic planning, and to implement some leadership training with our managers. That is my report. Any questions?
Yeah, so I was looking at your projection from this last month, and you guys were projecting using an average census of 131.31, but you're showing a census of 127.
That was right. That was
Right. What are we doing? Or
Yeah, we're up to 132.
we're up to 132 now. Are you doing anything else to recruit more patients? What are
We have constant referrals. We're not lacking for referrals. Yes. Now we've got to step maybe to accept more referrals. That's what it obviously
But I covered this already and I might have missed it, but how are we doing on contract staff at the moment?
We're down to
Direct care. Six nurses, then how many CNAs? Zero CNAs.
That's good. I think each of our administrators probably should also provide, I think, like Francis has provided a report of staff, DOH staff that you have that are paid under $12 an hour. That would be really, really helpful to us. And I think that you may have already done that if many, many months ago, but I think the under $12, right? Because we were quite surprised when Administrator Tweed showed us the number of clinical staff that she had that was paid under $12, which will obviously help you with recruitment, but then ultimately help you with less contract. Right. All right. What's that?
I said it won't help the budget.
It won't help the budget, but it will help your, but that's for, I was gonna say it's our job, that's his job. It's our job, but no, but ultimately it'll help your facility. One, you can take more patients, two, you will use less contractors, so it'll help your budget, I would think, clearly, right?
Right, it'll have a positive effect. So do you want that in like a raw number or a percentage or what?
I
or
think
both?
by-
Number, yes.
Just, we don't need the granularity.
Maybe, well, yeah, I think so, and probably a calculation of what it would cost to bring them to $12 an hour.
Are we just talking nursing that you want to know?
No, I mean, we would like the breakdown of all employees under 12, but it would be nice if you broke it up among clinical staff and non-clinical staff, because if we do have to make priorities, we're gonna make priorities to clinical staff,
You know,
administrators.
honestly, we don't need this. I think we got it through HR. HR provides that.
They already did.
Yeah, we have that information.
Okay.
We know the cost.
See, aren't you glad there's two people here? Any other questions from the phone or in the room here? Before we move on to the next presentation, can we confirm that we have a correct phone number? Because I think Dr. Massaro.
So everything's been confirmed and there's a correct phone number on there.
There is, and now he's being.
He's on, yes.
He's on now. Okay,
Yes.
great. No, he's not on now. I'm getting a nod.
No? Okay. He's been informed, so maybe he's taken.
Okay, but he does have the correct phone
He
number now?
does.
Okay. Okay, so we will move on with our next presentation, if this is the correct order, Jose Garola with New Mexico Rehabilitation Center.
Well, Jose Garola, Hospital Administrator for New Mexico Rehab Center. We continue to provide our core service provisions on our two separate units. We provide the intensive one-on-one therapy, medical care for patients who've had strokes, traumatic brain injuries, spinal cord injuries, motor vehicle accidents, disabilities, and those hip and knee replacements. We have 15 beds on the unit. The care is directed by our medical team 24/7 with intensive physical, occupational, and speech therapy in our programming. On our chemical dependency unit, which consists of 3 distinct levels, that's for patients who are seeking treatment for a variety of severe to withdrawal, substance abuse withdrawal, as well as substance use disorders. We have a chemical dependency with 8 beds currently, that treat alcohol, opioids, benzos, cocaine, meth, and other substance uses. The care is directed by our medical team 24/7 with licensed counselors offering both inpatient education, programming, readiness to change assessments, and further treatment to the next level, the next lower level. Our 28-day residential treatment program focuses on a multiple substance use disorders, which are primarily for adults who are exploring extended recovery options, sustainment through education programming, and a multidisciplinary team approach. We follow ASAM criteria 3.5, which is medically monitored intense care, which is closely followed by a counseling team, which engages with the patients in this 28-day program to address patient goals, emotional, cognitive regulations, and triggers that lead to some of those reactive states. We also, NMRC now offers 3 tracks of intensive outpatient programming. We started a new IOP program on September 23rd. This services individuals who are willing to participate or have gone through detox into our 28-day residential treatment program. Those in the community who just need more structure and support. So we follow evidence-based models, IDDT, in our education as well as in our programming to address those co-occurring and behavioral health disorders there. As our goals for IOP this next quarter, we'll be adding a multidisciplinary team meeting as additional program enhancement. For inpatient medical rehab quarterly census, this quarter we serviced a total of 32 patients that required medical rehab. It's slightly down from FY18 quarterly report. Our total patient days this quarter was 436. Majority of our referrals this quarter came from UMC Lubbock and UNM, which is great. We did receive 24 referrals, however, this quarter that didn't meet the functional status or appropriateness for rehab care. Our case mix index this quarter is lower than the regional and national standards in comparison. There's a reason for this, being that we service more less complicated patients such as those with lower extremity ortho type impairments, and of course due to our referral base. This quarter we did, however, have a significant increase in our stroke patients, which we admitted 21.7%. That's what we're standing at with stroke patients admitted. Our national average is at 23.6%. So that's pretty close. We're doing great there. Out of the 32 patients admitted on that unit, we did provide safety net care for 7 of those this quarter. So a large majority of the patients that we did service had Medicare, Medicaid. Our length of stay is slightly below the 90th percentile this quarter. Some of those factors include we looked into as difficult disposition, increased length of stay with those safety net service patients with either unfunded, undocumented care where it's hard to make another transition to the next level of care. We did discharge 81% of those patients to the community, which that's our primary goal. 5 of those were transferred to skilled nurse. One that was discharged to a higher level of care shortly after arriving to our facility. Our goal for this fiscal year FY20 is to increase our occupancy at least up to 80% on that unit. We have hired additional nurse and clinical support this quarter, which will help us to achieve this, hopefully this higher bed occupancy for this quarter. Chemical dependency unit. On our inpatient medical detox, we did service 72 patients this quarter. Excuse me. It's up 22 patients from last FY19 quarter. One of the goals is to ensure that patients that are discharged or are reporting for aftercare appointments are transitioning to a lower level of care, such as our residential treatment or into our IOP programming. We're holding about 87% for aftercare follow-ups in this area, which is great. We just had 3 patients this quarter that were just transferred to a higher level of care on our detox for some complications that around. Our IOP programs averaging about 40 clients served this quarter, which is up from last FY19 quarter. We did open up this new IOP track, which we increased our capacity up to 45 instead of the 30. Our collaboration with the 5th Judicial District is really greatly helping us to identify and actually as an additional referral base for patients into that program. We had 6 graduates this quarter. Our IOP hours have increased, again, due to the number of referrals, the number of clients in that program, to an average of 832 units and a total of 2,496 hours. In our inpatient residential rehab, we steadily increasing in occupancy since FY19. We have serviced 37 patients this quarter at 24 graduates. We're averaging about 15 patients served daily this quarter. Our length of stay on that unit has increased to 20 days, which is great, and our AMAs are lower this quarter. Occupancy is holding about 50%. We have submitted more information and policies procedures to our Human Services Division. We met with Myers and Stauffer for the rate development for negotiating for our provisional certification for our ARTC program. Looks like they're finalizing some of those steps, and we should have more, hopefully by next governing board. Eric, we should have a provisional certification for that. Right. Our goal in the next quarter is just to hire at least 2 more licensed counselors, another nurse on that unit to assist in that optimization, increase that occupancy up from the 50% to the next 80%. Accounts receivable, we collected a little over $700,000 this quarter, which is consistent.
Before you go on, I was wondering, so I noticed on that last slide, last 2 slides, that we don't have our bed occupancy measure. I was just wondering if in the future, if we can just start adding that, just reporting that piece of it, the way that we all decided on at the last meeting to report it.
Sure, absolutely. Great. So we did collect a little over $700,000. It's consistent with our previous quarter. We did have a large collection month in July, but this was partly due to the FY19 reimbursements that we collected there. Finance department's doing a great job in closely monitoring our AR accounts, our MCOs. We've been meeting with them, discussing with them, collaborating with them for a much faster reimbursement. Our 4-year comparisons. We're on track in our collections projections. We should see an increase in positive marks with this additional 3rd track of IOP, and as soon as that residential treatment certification gets implemented and we start getting reimbursement for those services, we should see an increased mark in our revenue. Capital projects. This quarter we completed our kitchen freezer generator project, which is a secondary power to our kitchen in case there's an emergency. That ended up costing us at least $34,000. That's completed. That went successful. We tested everything. Went great. Our attention and priority has been set as far as our capital projects to our generator petroleum storage tank. This quarter, we're currently working on that right now. We received a final report from our New Mexico Environment Department indicating that we need to make some modifications to protect the still gas tank from any kind of corrosion. We're working with Bernice and George, keeping them updated. We've come up with at least 3 options to help remedy the solution or the issue. However, it's looking that our 3rd final option would be most likely the best option. The estimated costs, they haven't been developed just yet. We're just waiting on a few more inspectors to give us some word on some concrete and some steel before we can actually get a cost for this project. But other capital projects that we have there include, our outside external repairs, our nurse call bell systems, medical bed upgrades, mainly due to age, the wear and tear over the years, and new technology coming out. Contract cost utilization for FY20 is about $642,000, which is less than FY18, but a large portion of our dollars is spent in our direct care support, mainly in our fusion and quick response staffing. That's our nursing as well as our PTA, OTA staff. Currently, we've utilized about $168,000 of that combined. Both of those contracts, we're closely watching those. However, with our recent hires in direct care, and our utilization of these contracts has been lower than last FY19 quarter. Still, our goal is to decrease those utilization of those dollars, which we're gonna see by next quarter, since we have more FTEs coming on board in our nursing. We had a good influx there. The direct care contractors, as you know, are just essential in maintaining that 24/7 care and support with our regulations in that rehab setting. But we'll continue monitoring it, reviewing our utilization. Our accreditation, last survey conducted 2018, we're approved for 3 years. We're still actively working on our PI projects as that were deficient from last Joint Commission. Our CMS survey from March of 18 as well. We're still looking, as far as mentioned, our approval for our residential treatment, our certification to get that provisional status. We will have some good news by next board meeting. So performance, there's new national patient safety goals around anticoagulation therapy that went into effect July 1. So we've reviewed, revised some of our policies and our practices around identifying and evaluating those patients that are at risk, the anticoagulation selection, medication management, some required documentation. We set our threshold to about 90%. We're inching closer to that goal. We'll be just ongoing education, training around some new forms and processes that we've instituted. We are diligently working on our ASAM treatment plan, our compliance, our individualization, especially as we seek this residential treatment certification, that they'll be closely monitoring and serving us under that. We've achieved our threshold continuously for the past 9 months, which is currently at 100%. We've made better progress in the identification, monitoring, reporting of MAR holes, med errors. This includes, decreasing those med errors this quarter. We've challenged the nurses and the physician staff to achieving these lower errors and adding incentives to the units, such as pizza parties, raffles, drawings, gift certificates. Sometimes we get into the mode of constantly looking at some of the issues and deficiencies where we're not focusing on some of the good that's coming out of it. We did notice a trend. We did notice fewer med errors, fewer MAR holes this quarter. So hopefully we can report better. We'll meet our threshold by next quarters. Other initiatives include our med reconciliation on admission, discharge, handoff communication with nurse therapy and counseling. We have a new project that kicked off October 1, where CMS has rolled out a new method for scoring functional status for rehab hospitals. It's a more complex series of questions that they want, which is going to be required from us on admission, discharge, and submitted to CMS on this patient data. This is important to us as non-compliance or non-participation will result in a loss of certification and up to loss of payments for this service. Our IT, DOH IT, developed a great electronic version of the form that we needed. We started this back in, it was about May that they started working on this. They did an excellent job in creating this form, so kudos to them. But we started this October 1. We're in compliance with the new rule as we speak. Patient satisfaction. We met our thresholds for patient satisfaction this quarter on MRU detox and IOP. We did score 89% in our residential treatment this quarter. We're just going to be revisiting the questions that we ask in that program to accurately capture some of their comments and experiences. We're working with our Eastern New Mexico University and OTA student program and adding additional activities to our residential treatment program. In June and July, students, they didn't necessarily provide activities during that time frame, which resulted in a deviation. So it was part of MD activities. Human resources, we filled, so far we filled 85 of the 94 positions. As stated earlier, we had this large influx of candidates. several key areas is nursing and some clinical support. Positions pending review and waiting to be filled are in nursing, counseling, and physical therapists. At this moment, I believe there's 6 clinical positions that we have left to fill. This is actually the lowest vacancy rate that I have encountered in the past 2 years as the administrator at NMRC, which is great. We're improving our onboarding process by meeting with employees during their first 30, 60, and 90 days. We noticed a better satisfaction from the employees by maybe they need more training, they need more help on our policies, procedures, or really in our processes. And it's standard, but our new HR person is really helping institute some of those programs and getting better satisfaction from our employees. Our needs and challenges, they still continue in direct care staff, around the licensed therapists, registered nurses, social workers. Like I said, the recent hires, pending candidates will really have an opportunity now to really review and observe, kind of optimize our patient care areas to determine any kind of additional needs or efficiencies there. We had a successful community event on August 3rd, which was our first and largest health expo in Chaves County. NMRC Foundation helped to sponsor this event with 107 other vendors who participated from all over the county. We're continuing to work with our 5th Judicial District Bureau Adult Drug Program. They have been essential in those in developing or enhancing our IOP services with the 3rd track coming on board. We attended, we can go to the next page. Right there's our community presence for our Health Expo, the little clip of the paper there, as well as a proclamation for that first annual Health Expo. So we're going to keep that one. Next, we did attend and supported our local Suicide Prevention Coalition event in September. NMRC participated in the Walk the Challenge, and excited to announce that we placed first in the Southeast region again. So that's great. We averaged about 73 case steps per person. This evening, the Mayor Health Care Solutions Committee in Roswell is hosting this large appreciation dinner and social event for our physicians and provider staff in Roswell. Representation from local hospitals, clinics, other health facilities will be present. Our physicians will be attending this event, really just to engage them and really support them, let them know we appreciate them in our community. Local hospitals, they still continue to be our, we continue to meet with them really for our referral basis, making sure that we're participating in their accountable care meetings and discussions around how we can improve the patient experience to the admissions, discharges, and the continuum of care. We met with the public health department. We discussed the topics of medication-assisted treatment, collaboration around substance abuse disorders, including the screening population that we serve, refugees. So we're excited that we'll be meeting with them next week with Jimmy Masters there and start the preliminary planning. Our goals and success this quarter, our new collaborative efforts in our inpatient residential, pending our inpatient residential certification, our 3rd track of IOP, and the enhancements of services. We've got Dr. Vickers now, who's credentialed with NMRC, providing those neurology services for her patients, but also as a consultant for neurological care on our medical rehab unit. We've credentialed our general surgeon wound care specialist, which will be essential as well to helping us treat, identify, even educate some of our nursing staff and physician staff on how to appropriately care for burns, other wounds and ulcers that we can't manage. Any questions?
Yeah, back for your budget projection a while back. You said NMRC is experiencing issues with IOP claims being paid for all 3 hours of service for IOP.
Yeah.
Since Medicaid changed the guidelines,
The reason
that issue?
So HSD, they sent out a letter stating that we, instead of billing 3 units, we got a bill 1, but with the 3 added. That created so much confusion across the board where we were used to submitting 3 separate claims for IOP, 3 separate hours with the service. Now they just want it with one, but all tied in. It's yeah, it created a little bit of delays, but we're working out the kinks in the mud.
That's been worked out?
Yeah.
I have a couple of questions. The first one is the IOP programs. How far is the average patient? Because it's outpatient.
It is.
How far, like, where's their catchment area? How big is it?
We have patients currently that we're serving. They've gone 24 weeks. They're 24 weeks in IOP, so 16 to 24 weeks. I'm noticing that's where the graduation occurs.
But I meant the geographical catchment. Are they all in Roswell?
You know, Chavez, they're local. Chavez County, Ruidoso's Lee County. It's just within our region. They don't come from Bernalillo or other
Or even Alamogordo?
Right.
It's too far.
It's too far. Right.
Okay. And the next, I just wanted, more of a comment, I think, creating a pipeline between the judicial system and your chemical dependence unit, I think is an incredibly good idea, and we should foster that in the future, for all of our other institutions.
We've noticed better.
Becoming a model, a highlighted model across the country, right? So
we've noticed better compliance from the patients. Not necessarily them having to be there, but the monitoring from both sides. They know legally they've got to comply with this, treatment-wise, it's working both ways. It's helping us fill up that.
Now in that part of the state, do you have any sense of what kinds of problem-solving courts they have down there as far as drug courts?
Right now, it's just adult drug court. They're looking at an adolescent drug court. However, we can't, that's out of our hands, and they're asking CYFD maybe for some help around that.
I'm wondering, in our future facilities meeting, we should probably talk about the interaction with the judicial system. I think we should probably go through across all for various patient populations, and everywhere from adolescent to behavioral health.
And I may have missed it, but were you able to fill that position?
Yes, we were.
Specialist position.
This is where we filled it. That was one of our positions. Is actually, I take that back. We do have the action ready to go and signed. Thank you. The offer, it's still pending, but the person's
Waiting on the person.
No, it's pending on SPO right now to deliver that to us, so we can make the offer. But again, we've got the candidate, we got the person. They're willing. They're already starting. There hasn't been any kind of gap in our service that we're providing in the collection. She's been sharing, going back and forth.
And I believe they submitted the documentation last week, and so yesterday I got a note saying if I could look into the status of it. This was late yesterday.
It's been seamless right now. There hasn't been an issue as far as our collections or our downtime.
I'll check on that.
Are there any other questions from here in the room or on the phone? All right, with that, we will, thank you for the presentation. We will move to Administrator Alikar, Los Lunas Community Program.
All right, good morning. For LLCP service provisions, we provide supported living, and that's to assist those served to live as independently as possible, providing supports designed to assist, encourage, and empower those served to grow and develop, gain autonomy, become self-governing, and pursue personal interests and goals. We do have crisis residential. We serve as the statewide crisis support provider for individuals with developmental disabilities. And we have a intermediate care facility for individuals with intellectual disabilities. And this is a 4-bed ICF MR program specifically designed for individuals who have been convicted of a violent crime but have been determined incompetent to stand trial. We also have customized community supports, which is our day hub program. We assist adults with developmental and intellectual disabilities to increase independence, strengthen the ability to decrease needed pain supports, establish or strengthen interpersonal relationships, join social networks, and participate in community life. We also have community integrated employment, where we assist adults with developmental and intellectual disabilities to become employed in the community in jobs that increase economic independence, self-reliance, social connections, and career development. Our census data for Q1 fiscal year 20, for supported living, we have 59 individuals. Crisis in residential, we have 1. Customized community support, 62. Community integrated employment, 21. ICF, 3. And total Jackson class members is 34. Our financials for the quarter, billed 2.5 million and collected 3 million. Our 4-year revenue comparison, right now we have a total of 2 billion. Previous years are between 16 and 18 million. Capital projects, we have several. Cottage 3 and 4 parking lot flooding is pending and it'll be started soon. Demolition of Don Pasquale apartment complex, White Administrative House, and red bricks has been started in October. Campus lighting has been started in October. Cottage 6 and 7 renovation is pending. Water irrigation infrastructure mapping, the mapping has started. Cottage 3, 4, and Burroughs interior upgrade, there are plans being developed for that. Roadway parking and sidewalk repairs are scheduled to start. Replace rooftop unit at Cottage 4, that was completed this week. Guard shack and entry, we're working on that. Don Pasquale renovation, that is pending. The RDN fire detection, suppression, and securing the facility is in process. Campus security is in process. Campus signage, we have a couple plans that have been presented, so we're working on that. The maintenance building plumbing repair is currently being worked on. Contract cost for nursing, the subtotal is $76,000. Residential care and oversight, $13,000. Maintenance, $6,000. Employment and security, $3,000, for a total of $99,552 for the quarter. Licensure and accreditation, we currently have 3 current occupants at the ICEA, with 1 bed that is vacant. For DD waiver services, there were no DHI Quality Management Bureau activities this quarter. And for our IQR, we have 3 individuals that were selected for this round. All required documents have been sent to DDSD, and our interviews will begin on October 31st. Our performance improvement indicators for this fiscal year: individual service plans implemented as written, percent of appointments attended versus made, percent of individuals receiving CCS in non-disability specific settings, our compliance with reporting requirements, review of GER event date versus approved date, review of A&E discovery time versus report time, summary of weekly audit activity, and our e-chat compliance report. For human resources, we have a total of 295 positions. 243 of those positions are filled, giving us a vacancy rate for the facility of 17.62%, and a vacancy rate for direct care staff of 18.36. Workers' comp injuries, 5, and we have 15 people out on family medical leave. For the month of July, we had 0 hired. We had a 3.21% turnover rate and a 26.1 vacancy rate. For August, we hired 6 staff with a turnover rate of 1.66 and a vacancy rate of 18.64. In September,
Can I ask you a question about that? Is there a rapid hire in September?
it was in August, and so they were,
Sorry, it's in August and they
and
processed.
they processed for September. So we hired 22, turnover rate 1.64, and that brings us down to 17.62 for our vacancy rate. For recruitment and retention, on July 13th, SPO approved appropriate placement for all site techs, home health aide, and nursing positions. We had a few staff that were upset that their percentage was not higher, but the majority of the staff were very happy with the increase. The increase has helped to retain current employees as well as successfully hire new employees. We're now competitive with community providers as far as salaries. On August 21st, we had a rapid hiring event for site tech, home health AB, certified medication aides, LPN, and RN position. This was our 3rd rapid hire and our most successful event to date. We had 41 applicants attend. We made 34 contingent offers. Out of those offers, we successfully hired 26 new site techs and home health aides. Our needs and challenges. Currently, we have our LPNO positions posted, and they've been posted for more than 2 years with minimal applicants. When we do get applications, they reject the offer due to the pay. We are requesting to reclass these positions to LPNAs in order to recruit and retain LPNs. We are currently using agency nurses to meet our needs for these vacant positions, which creates a huge impact to our budget. We have 2 agency nurses that would apply for these positions if they were LPNAs, and this would significantly reduce our contract costs. We are in the process of reclassifying a position, which is a downgrade, to a custodial position to eliminate a cleaning contract. This will provide the facility with services 5 days a week. Currently, the cleaning contract only provides services 1 day a week for 5 hours, which is not adequate to clean and maintain the administrative offices on campus. Budgetarily, there will be little impact to the budget. This full-time position will cost relatively same as the contract. We're also in the process of reclassing one of the social community service coordinators to a residential coordinators, which is a business op. This will allow for the houses to be distributed equally and fairly to ensure all duties for the positions are being met. And our activity.
Before you go on, do you mind just putting a note down to follow up with us on this LPN, that first bullet on the last page?
Okay.
LPN.
Because you have, it applies here that you already have 2 applicants. They would convert from contract nursing
Two of our agency
to
nurses are
employee.
interested.
We should get that done right away.
And we tried to, we've been working on it, but we haven't been able to get it pushed through.
Well, we'll assist with that.
Okay.
That makes sense.
We recently converted one of our contracts to an LPN supervisor position because we were finding competitive.
That's great. If that's like the easiest way to do this, right? Yeah. Yes, just let us know if there's anything that we can assist in. Tammy, send us a specific note and we'll walk down to HR.
Okay.
Thanks.
And we participated in Week of Wellness, and we met all of the 7, I forgot what they're called, 7 things that we were supposed to meet. Anyway, so we had the water challenge.
Okay.
There was like environmental, emotional, spiritual. So we met those. For our planting, we did get a donation from Lowe's for a tree and several flowers. So we were able to plant those.
Dimensions.
Dimensions.
7 dimensions.
Thank you.
I have to look at my.
And that
Did your employees like the adult coloring puzzles?
They did, and one of the staff actually created a crossword puzzle with LLCP words in there. They tell us it means.
Does anyone have any questions for Administrator Alikar? Go ahead.
I was just wondering, you know, I went down there a few months ago and I saw that there's a lot of challenges with your fleet management. What has transpired between, what was it, maybe 2 months ago, and now to kind of deal with that? Have you done anything on that?
We've been working on getting the vehicles that we have repaired. We still have one that is at Forley's for repair. We have two that are out for like body.
Vans or cars?
3 of them are vans and 1 car.
Are they big Fox vans? Not now Fox, but you know, the big.
Handicap?
No, not those. They're like the
So we're working
the
on
Dodge
getting
Caravans.
the
So
maintenance
we're
done.
getting
These are ones that wheelchairs could not get to. Like, there's not a lift,
Right.
correct?
Hasn't Corley's had that for a while already though?
Yes, and we looked into that, and what we're wanting to do is go from just using Corley's to getting bids. Because as we looked at it, it kind of looks like Corley's is just sending us a bill for whatever they want to charge us. Because it's not matching the services that they provide. So we're wanting to do bids instead of just giving Corley's.
What kind of work is being done there on that vehicle, do we know?
Various types of services. Can I chime in? Okay.
Yes, please.
ABS, brakes, tire, brake pads, lots of different things, all kinds.
Yeah.
Belts, replacement of belts. So,
Seems like
yeah,
a
they
lot.
constantly, at least once a week, have POs associated with vehicle maintenance services. We also asked for some replacements from GSD. We did
Okay.
put in an order. So we
Will
should
we
see.
replace this particular vehicle then?
There are multiple vehicles we would replace. This particular vehicle, yes. But we have not worked on the vans, the wheelchair vans quite yet with GSD. That would be our next step.
Okay, we should put that on the agenda for sure. Yeah. Any other questions? Great, thank you very much for that presentation. We will move to Administrator Hartley with Turquoise Lodge Hospital.
Okay, my name is Shauna Hartley, and I'm going to be presenting the Turquoise Lodge Hospital Governing Board Report, Q1 FY20. So the services that we are providing are medical detox, 3.7 ASAM-driven medical detox program, 20 beds in our new facility. We have a social model rehabilitation program, 20 beds in our new facility, 3.5 ASAM-driven program, and then we have 1 track of IOP. This is the first time that I'm reporting in the last 6 years that I've been the administrator that we are no longer providing the medical staffing for the county program, the MOTU contract. That ended June the 30th. However, our nurse practitioners stayed on board for 3 months after that, providing intermittent services because the new vendor that had taken over wasn't able to staff it 7 days a week. Our bed capacity for this quarter, even though we did relocate our facility in June, we do have 20 beds on both sides for detox and rehab. I did identify our beds as 16 on both ends because of some residual punch list items that had to be taken care of, so I had some rooms that I couldn't occupy. We had some sewer issues, and we had a roof leak that was quite chronic. And so next quarter, I'll be identifying our bed capacity at 20 on both ends, but I did have to be mindful of some of the physical plant challenges that we had this quarter. We did service 194 people in our detox program. We serviced 80 people in our rehab program, And if you look at the hospital occupancy, we were at 80%, which is pretty good after a relocation process. Sometimes, you relocate a facility and you're at risk of losing some customers or that being a challenge. And I think myself and my staff did a pretty good job keeping that alive. If you do look at our last couple of year data information, what you're going to see is that we are servicing less people, and the reason behind that is we have hired a medical director that is doing inductions for medication-assisted treatment, and so our average length of stay for our medical detox program used to be a really hard line 7 days, and now it's somewhere between 1 and 10. So that bed availability is just varied based on our new medical director direction. For our intensive outpatient program, we have one track. We have IOP that goes Monday, Wednesday, Thursday, and Friday from 1 to 4. In the next quarter, what you're going to see is, I think, just a revamping of my clinical department. In the previous quarters, because we were kind of bumping up into this move, we were kind of getting more and more limited space up into the relocation process, which would limit our capacity to actually hire clinical staff and for them to have an office and a place to work. So we are in the process of reclassifying some positions, really creating a robust clinical department in hope of including one more track of IOP, in addition to starting an addiction medicine clinic where we're going to have individual therapy and family therapy, individuals ready to do treatment plan reviews, comp assessments, and so this is going to be a whole revamp of creating some outpatient services for Turquoise Lodge Hospital that I think is going to be really exciting. We had an average census. We can take 15 people in our matrix track for IOP, and our average census for the quarter was 7. Our financial data is pretty steady. We did have a pretty robust July, and that's because of prior year collections that we had. And so these numbers are pretty much the same every quarter. We are experiencing some challenges with a couple of different things. Now that we are doing inductions with medication-assisted treatment, you are providing medications to prevent withdrawal. Therefore, you're not going to get authorized for care because you don't have any detox symptoms to report. So that's one shift with our revenue collections that I'm very, very mindful of. The second one is that, and I'm collecting the data at this point with the new customer that we're really servicing, are individuals who are smoking methamphetamines. And the insurance companies really don't acknowledge that being a detox process because they don't require detox medications to detox from that drug. They really just require comfort medications. And so me and my medical director are working actively to put together, a different perhaps track or line for individuals who are coming into our hospital using methamphetamines. My 3-year collection data, every year we go up. In 17, we were at 2.5 million. FY18 went to 2.7, and FY19, 3.4. I would say that those 3 years that are identified on this graph did include the MOTU contract, which was about $800,000. So this next fiscal year will be my first fiscal year without those dollars, but I'm actively trying to make that up, being very mindful that we are doing inductions with medication-assisted treatment, so my authorizations are going to decrease. I've been working actively with the courts, as Jose has in his community. A lot of people are interested in having their customers come through our hospital, through our rehab program, and willing to pay for that. So we did establish a contract with Metro Court last quarter, and that's about $80,000. And then in our successes, I'll talk about the 2 new systems that I'm trying to align with. Our contract costs pretty much have stayed the same. We had 0 agency nursing dollars used this last quarter. I think like everybody else, we've had some successes with the increases in the nurses' pay and their salary, and so it's not that it's not a challenge still. but it's definitely less than it has been in previous years. One thing I'll say is that our medication costs have gone up dramatically, and that's for two different reasons. One is that we are now a tobacco-free facility, and so we are purchasing large amounts of tobacco cessation medications to help our consumers and obviously keep them in our program during the time that they're with us, in addition to the medication-assisted treatment. Medications are quite expensive. So in this last quarter, we've done a lot of work around preparing for Joint Commission, which I'll talk here a little bit about in a minute. In the last quarter, we really have gone through quite a bit of a transformation. Operations changed 100% in the sense that, I relocated the entire facility. We did it occupied. My staff went through quite a transition working in a new environment. And when you move into a new facility, it does take a while to get on your feet. So in the last quarter, what we've done is myself and my finance director and the individuals that do the utilization review outreach have really worked hard to make sure that all of our stakeholders are aware of our new location. I've been doing a lot of tours for people coming by, showing them our new environment. We've had to do quite a bit of safety assessments in our new facility, and that has ranged from sound to lighting to the waiting room to the signage to basically just learning how to operate in our new facility. We've had to do a lot of work with my staff in learning how to work in the new facility as far as the location of different things. We have a dining room, which is different, where we have a food vendor that brings the food, and our patients now have choices, which is in line with Joint Commission preference needs. And so that has taken some time for my staff to really work with that new food vendor and learn that new process. Operating in an environment that is not 2 stories versus 1, extracting the programming because I had to push it together for a period of time because we were kind of pushed into one space prior to my relocation. I've had to extract all of that, ensure that detox and rehab has their own individual programming, and then there was some residual punch list items that had to be addressed. We have submitted our application for Joint Commission. My ready date has been identified December 2nd. Our Medicare application has been submitted, and everything is a go. So we will be ready to go through accreditation in December. With our performance improvements, we've actually done quite a bit over the last quarter. I'm making sure that all of our agendas and our leadership meetings, our EOC meetings, medical staffing meetings, all are in compliance with Joint Commission accreditation standards. We have worked quite a bit on improving my documentation for my medical department. I'm proud to say that we have our history and physical in Avatar. So 100% of my physicians and my nurse practitioners are actually utilizing the electronic chart, which is not an easy task to ensure. We have electronic medication reconciliation document, and we've also created a report that is a snapshot every morning where I know exactly a roster with every consumer, what day are they in my program, what insurance do they have, and how many days have been authorized. My new medical director has also established a process for simple procedures, and that really is for individuals who have abscesses. So traditionally, we were sending people to the hospital, to the ER, if they had an abscess that we were not able to address. And anytime you send someone to the ER, you're at risk of them not coming back or being given pain medications and those types of things. So she's actually doing those simple procedures at our hospital, which has also assisted in keeping the customer that we have. We started a rehab multidisciplinary treatment team this last quarter, where I have nursing represented, clinical and medical. So we are very vibrantly looking at the treatment plan with the consumer, and they're a huge participant in that process. We're looking at outcome measures that I will be rolling out this next quarter that will give us the evidence of the efficacy of our program and really provide my staff with a baseline of every department and every system. I have very candidly looked at my access department this quarter, and that was actually based on a complaint that we received around just not consistent information given to our stakeholders about our bed availability and when people can get in. And that was a really good experience for us, because what I found is that we have grown that department, and in growing that department, there's 2 different supervisors. So we pulled everybody together and really kind of dissected some of the challenges with that. So anytime you have more people answering the phones, disseminating information, you really have to be more astute at making sure that that information is accurate. We actually started this last quarter providing people appointments for their pre-admission assessment. So prior to this last quarter, we were saying a nurse is going to be calling you back, and that, that's not the best way to go with the customer, because they really want to know when that's going to happen and what time that's going to happen. And so now all my access staff have access to the nurses' schedules, and they're plugging those appointments in, and there's a responsibility of the nurse to be calling those individuals back at the times that have been identified. And so that's been a huge improvement to my access department. Our patient satisfaction information, stay tuned next quarter, because it's going to be much more robust than today. We, at this point, are providing a patient with a patient satisfaction survey, and we do, pretty well in the satisfied categories. Somewhat satisfied is where we hit. Our lowest number this quarter is 2.5, and that has under the domain of preparation for leaving. And that's a really tricky question, because when people come into our detox program, on day 3, our clinical staff are actively trying to sit down with the consumer and talk with them about what they want to do when they leave, or what their interests are. And a consumer is not always well enough to participate in that conversation. And so sometimes it gets pushed out a bit, and people feel a bit rushed. And so we are taking a look at that system and seeing what we can do more mindfully about assisting the consumer with their next step. Next quarter, I'm really planning for a huge outcome rollout. With our detox program, we're planning on aggregating the SIVA and the COW documentation, presenting the customer with a stability assessment, and in our detox program, actually following up with a phone call to see if that customer got to their next appointment, and also whether they continued on their medication-assisted treatment program. In our rehab program, we are going to be looking at a pre-post assessment, perhaps the VEX anxiety and depression scale, and really taking a look at that consumer stability when they come into our rehab program and when they're discharged. Our vacancy rate, we've stayed pretty steady, about 28%, 27%. I really see that decreasing in the next quarter, because we're going to be revamping our clinical department, looking at some positions that I've historically had and new positions that we need for this new approachment and services. So in our last facility, I had quite a bit of vacancies for site techs and direct care staff, because I was staffing 2 floors, and now that I'm only on 1 floor, I'm looking at reclassifying those positions to clinical positions, because I also want to grow the addiction medicine clinic, which is going to require more licensed clinicians. We have done, fairly well over the last couple of years with our marketing and outreach. We've actually purchased items for my staff to wear and give out when they go to different events that we are invited to. September was Recovery Month for the world, and we were invited to quite a bit of different events, and actually got to host a couple of our consumers, speaking at them and us supporting them in doing so. We try actively to do at least 3 events a month, and we were successful in doing that this quarter, with the exception of August. And this next slide really highlights those continued community events that we were a part of. We also met with public health, as Jose talked about in his report. We are trying to team with them around consulting around medication-assisted treatment, perhaps doing some telemedicine in that area. and them helping us with some STD assistance, and also having maybe one of their nurses actually come to our facility and do weekly educational groups around hepatitis. Our needs and challenges, we do want to hire a psychiatrist for our impending addiction medicine clinic. And, you know, any of us in this room, we all know that there's just quite a limitation of psychiatry in New Mexico. I've had that position posted for some time, but I haven't been successful in hiring somebody. I did meet with a physician 2 weeks ago, and we went through our program, and she got to take a look at what we're doing. And so I'm hoping to stay in contact with her. You know, it is a bit challenging. I know the nurses got a big bump in pay, but the clinical staff are pretty underpaid in our state system at this time. And so I have a lot of clinical positions posted. I do have some challenges with actually having people apply. And then once they're offered the hourly rate, you know, they are getting better offers in the private sector. I am still trying to really shore up my billing system because I'm in preparation of starting an addiction medicine clinic where my claims are going to go from per diem rates to individual claims, which is going to require a much more robust billing system to back that up. I have had some challenges with my bed capacity just this quarter based on the physical plant challenges that I talked about earlier. And I'm hoping that the Department of Health is really moving forward with us getting a Pyxis machine here pretty soon, because having two non-hosted DOH IT systems to enter these order sets and that be on paper and disconnected from the pharmacy is just an efficiency issue. It's a patient safety issue. And I think if we move towards that Pyxis machine, we're going to be all in better shape with safety and just efficiency. Our successes and goals this quarter, we're continuing to give out many Narcan kits, participating in self or harm reduction models with all of our opiate patients. I feel like my staff are really fully functional in our new facility, which was a big task. I have been meeting with SLEDA Behavioral Health Services and District Court for these new relationships. And I'm really excited about SLEDA Behavioral Health because they're willing to, I meet with them tomorrow morning actually, and we're gonna kind of walk through a potential contract where they're gonna hold a bed for detox and rehab and pay for that every single day, with the idea that if they needed that bed filled by one of their members, that we would do that immediately. So that's pretty exciting. I have met with District Court as well. They're looking at paying or wanting to look at providers to provide rehab services, paying us for the rehab stay for 18 to 21-year-olds. We have met with public health, as I said, and we are meeting actively with different methadone clinics. So something that we're doing in our hospital, which is really exciting, is that we are now bridging people who are wanting to stay on their methadone but need to be detoxed from other substances. And I have my staff actually transporting the individuals to the methadone clinics every day so they can be dosed in that setting, so they can continue on their opiate replacement, be detoxed in our hospital, and stay connected to the methadone clinic where they've been getting their opiate replacement in the community, which is not an easy task to do every single day, and make sure that you know, the consumer is able to see the counselor and able to do all the things that they need to do in that setting. In the last month, we also participated in the Department of Health Wellness Month and also recovery activities. We also provided a lot of opportunities for our staff to get acupuncture and salsa. We had a kickball game with Sequoia, which we lost, sadly, for the first time. We had yoga and a painting class, and then we had our 67th birthday celebration last month, which was really nice. And that's the end of my report, and if you have any questions.
I do. On your psychiatrist position, what can we do around telemedicine on that if we can't fill it?
I don't know. I mean, I guess I would have to team with a facility. I'm looking at Francis. I have to team with a facility that has psychiatry services, and we could definitely talk about that. You know, I think that telemedicine is really the future. I don't know if we're all going to have our own physicians in that arena. And so I think that that's a really good conversation.
I think we have to include IT. Right now, we're doing some telemedicine to Santa Rosa, to Pecos, but we have to do it through Skype, business Skype, because we can't really do telemedicine like other hospitals do. Because of the firewalls, is what I've been told. So we really need to include Terry in that conversation, because I absolutely think there's some.
You think you guys have the capacity to offer more?
Well, we did until last month when I lost 2 providers at outpatient, but we're really trying to get that replaced, so I think that we could help out, absolutely. And I mean, we could do it internally through Skype.
But even if you sorry to interrupt, but even if you contract your telemedicine work, it's much more affordable because you pay by case as opposed to pay by the entire provider, right? And so it still may be beneficial if we're having, because for instance, your providers may be already overwhelmed that they're going to take more cases by telemedicine.
Well, it would be outpatient, right? It would be our outpatient providers, and I think once we're fully staffed, that's doable, especially to our sister facilities. And it could be case by case basis, so I think that's something we need to explore.
Yeah, or even check with Dr. Collins, he might have, I mean, he has a good handle on people or his colleagues, and somebody might be interested in that.
We have some former psychiatrists who want to do telemedicine. You know, they've left, they've opened up their business, so I can think of 2 of them right off the bat that would probably be willing to contract your Department of Health to do telemedicine if we could get the IT piece figured out. Because they've always said they can't, the firewall, but you know, they can't come in. We can't do it with outside people because of the firewall. So I
And
think
there's
it's
local
worth
companies
exploring.
that are doing this work. UNM is contracted with Medical that does this, right? And I think we use that medical services over it.
Well, I think it also has to do with like bandwidth in these smaller communities.
I have 2 questions, because of time, really briefly. First, tobacco cessation, Shauna. You said your cost of meds was high. Are not those medicines available through 2PAC? If you have a patient go through the 1-800-QUIT line, then they're provided for free.
They are, but the timeliness of that turnaround isn't fast enough. So when the consumer is admitted.
So they're only there for 7 days.
Yeah.
That's really unfortunate because DOH is already providing those medicines.
It's a mail service, right?
Yeah.
Yeah.
But they're out so soon.
Yeah, the turnaround, we met with them when we were planning on going tobacco free.
Yeah.
We met with them and tried to go down that road, but the turnaround time, you know, the minute the consumer comes into our program, they need to have the tobacco cessation medications.
So why can't we just stock?
Why can't we just stock them? I'm thinking we should talk to 2PAC again. So if you send us an email, it makes no sense, right? You're taking dollars to buy these things that we're providing for free 8 days later.
Yeah.
So let's find a way to do that, because we already are procuring those medicines for the 2PAC program. We should find a way to have some on hand.
Okay, so send you an email?
That's an easy one, because we already have those. And the second one was, you know, I thought the really scary part about the work that you do is the methamphetamine part of this. For those that don't know, there's really no treatments for methamphetamine intoxication or detoxification. Though there's no study that shows anything works. There's a few studies that say the only thing that works, and I'm surprised that you're not getting payment for it, is 30 days of sobriety and a job.
Right.
The key is the job at the end. Like the methamphetamine abuser needs to have something to do that next day other than that. So if we do start to have inpatient detox for meth,
which we do now.
Yeah.
I think what we're experiencing is that customer, you know, they just don't stay.
I know.
The minute they're comfortable, and that's usually day 1 or 2.
Yeah, after it's out of their system.
They become very, very deregulated, and then they just keep coming back.
I'm wondering, and we work on this offline as well, but combining forces, because the part of the job at the end is maybe like working with Workforce Solutions of like finding jobs that if people went through their sobriety program, you would link them to some sort of employment opportunity at hand, because that's the only thing that has been shown to be successful. So that might be some incentive, create some incentive to stay, but you're right, that's the problem with the methamphetamine detox.
All right, so just super fast, I'm looking at the Medicaid billing supplemental. I don't know if you guys have seen it, but I'll just read from it. It says eligible facilities to be eligible to be reimbursed for providing ARTC services to an eligible recipient. An ARTC facility, and it lists off a few different things, but one of the requirements is must provide a medication assistance fee. Now, I know you're doing that already, Shauna, but Jose, you're not doing that yet, right? And I'm not entirely certain that what you're doing, Shauna, is, I'm not sure we've set up that kind of continuum step down with the MADSIN, have we?
Well, you don't have to do it on a continuum, you just have to make sure that you're linking the customer from your inpatient to outpatient, and we're definitely doing that. Yeah.
Yeah, we've got our resources within our community where we refer for.
And Roswell as well, so
Roswell. So are you're able to leverage that MAT that's in Roswell for your services? In other words,
Right after.
That's why you're able to bill for the ARTC.
Good. Just with time, if we can move on. Sequoia Adolescent Treatment Center will not have a report by Carmela Sandoval today. It will be made available to the public as soon as it is available. Do we have an online?
We do.
Okay, so it will be
Oh, no,
presented.
actually, I don't have anything.
Because it's not completed yet. We will have that quite soon from her, and it will be published online. With that, we'll move to the State Veterans Home and Administrator Deason.
Good morning, co-chairmen and members. I'm Donna Deason, Administrator of New Mexico State Veterans Home and Truth and Consequences. I'm going to run through this as quickly as I can. Service provisions. We offer round-the-clock nursing home care, skilled nursing services, and domiciliary. We are licensed under assisted living for a domiciliary, that's a veteran designation. Services to veterans, spouses, veterans, Gold Star parents are our customers. Therapy is provided 5 days a week. That includes physical therapy aid services, restorative aid services. Speech language pathology is also offered. We have one full-time physician who is our medical director. We have a pharmacist who is our pharmacy director and pharmacist clinician. We have an activities program that offers recreation therapy 7 days a week. Summary of occupant days, Medicaid in July, 1,580, private pay 1,269. Other services such as SV vets, that's our 100%ers, 703, Medicare 0, and DOM 72. August 1,700 in Medicaid, private pay 1,170. Other days 736. The other days are 100%ers. Medicare 31 and DOM 62. September we had 1,140 in Medicaid, 1083 in private pay, 673 in 100%ers, and Medicare was 110 with a DOM 60. 3-year revenue comparison. July for FY18, let's see, we were at 1.5 mil, in July we were at 1, and in, let's see, that's 2019, 2020, we were at under a mil. In August, for FY18, we were over a mil. In FY19, also over a mil. In August, under $1 million. September of FY18, we were over a mil. And in 19, we were at a mil. And this year, we're under a mil. So these are our total for the 3-year comparison. Contract costs for court. Nurse staffing, Prime Time is one of our agencies. Budget for FY20, 900,000. Allocation 225,000. Expense 461, 185, 35 at 205%. Rapid temps Budget 350, allocated 87,500, expense 132,906.88 at 152%. Subtotal 1.250 mil for budget FY 20, allocated 31350 and expensed 594,192.23. Therapy staffing, center tab. That is our physical therapy PTAs, and our speech language pathologists. We are budgeted for 300,000, allocated 75,000, spent 71,000. Dietitian is Global Nutrition. They are our dietitian that oversees our plans. Budget 31,500, allocation 7,875, expense 5,269. Medical services, Sierra Vista Hospital. That is our local hospital that we utilize. We are expensed for our budget is 50,000, allocation 12,500, expense 9,619.82 at 77%. Backup MD 25,000, allocation 6,250, expense 5,698.89 at 91%. Backup pharmacist 25,000, allocation 6,250, expense 5,254.02 at 84%. Dentist 4,000, allocated 1,000, no expense 0%. Other services that we contract are medical records, 6,000. We've allocated 1,500 and we expense 1,562. We're at under 4%. Trainer 23,750, 5,937.50 at 0%. We have not utilized that money yet. Barber 7,500, allocated 1,875, expense 1,393 at 74%. Beautician 8,050, budget allocation is 21,8750, and expense 1,611 at 74%. So the total is 1,731,500 allocated for 2,875 and expense 695,841.74. Thank you. Capital improvement project in progress. When I was going through the capital improvement projects, I was going to do the projects that were completed and the ones that were in progress. All of ours are in progress, but very close to being completed. So at our new annex, the exterior, at our main building, exterior sliding doors for the main building, pending a PO quote. Maintenance shop, power plant roof replacement, HVAC completed. HVAC is in process. Annex, memory care, geotechnical testing, and report for our courtyard in the annex is in progress. Kitchen, dining room, multi-purpose room, and the main room, HVAC replacement is very close to being completed. Cooler, walk-in freezer replacement, again, that one in our main kitchen is almost completed. We had a collapsed tunnel with, and that's being investigated, and repairs are in process, and we're in the process of getting that updated. Annex HVAC repair is halfway. The repairs are being done. Now we're doing electrical. System assessment therapy pool, that's being engineered. Annex falling stones in our gates. The outside of our new annex, the facades, the stone facade is falling off, so we are getting that replaced. Repaired sidewalks, drainage, parking lot, security cameras for the facilities at the main building, hail and flood damage, ADA ramp upgrades, sidewalk replacements, lighting, drainage improvement, plumbing, boilers, heat. I want to thank George, Morgan, and Chris Sinclair for all the hard work they are doing to help us get our facilities back and updated. Projects also are repetitive, so ignore that next one. License and accreditation. CMS annual survey was conducted September 9th through the 17th in 2018. We are in the window for our annual survey. We're getting a little tense because it seems like they're waiting a very long time to come and survey us, but that's okay. You always have to be survey ready at all times. I want to thank Todd here. He got me onto the compliance store that is helping us with getting prepared for our surveys. Very good product. And I can have all my staff on there for nursing. So, VA annual recognition survey was conducted November 6th through 8th. 2018 survey is due in November 29th. And I am in contact with that group. Quality and performance improvement. Performance measures, adverse events, near miss monitoring, revision FY20, expansions of performance measures trending to improve quality. Committee oversight, adverse drug events, significant medication errors, hypoglycemic events, and anticoagulant events therapy. Catheter-associated UTIs, falls with injury, pressure injuries, abuse, neglect, exploitation, allegations, sentinel events. Antibiotic stewardship initiated a provider assessment 48 hours after an antibiotic is started. Current compliance at 86%. This is a difficult situation. Cultures take 3 days to do. So the new regulations require us to do that in 48 hours. We have a plan in place to complete our compliance higher than 86%. Casper report. Weight loss. Casper report improved from FY19 average of 9.7% to 4.3% for the first quarter of FY20. Quality committee developed a team to improve accuracy of resident weights and improve to 99% compliance. So, performance action teams, PATS. Infection prevention and control, address an increase in urinary tract infections. Nursing documentation, improve documentation on medication administration, treatments, and behavior monitoring. Staff satisfaction surveys, review, recommend follow-up on survey findings. Food service hand hygiene, increase food servers in the annex and improve hand hygiene practices. Resident satisfaction survey. Resident satisfaction surveys are conducted for nursing home and domiciliary care to address resident complaints and overall quality of care. Fiscal year 2019. Next satisfaction survey will be for fiscal year 2020. So overall satisfaction for a resident survey was 86%, medical staff 88%, nursing 86%, other 85%. Human resources, hired for July 0, August 12, and that is a result of a rapid hire in July. September 1, I look to the next month to having more hires. We had 17 lists out there, and we're starting to actually get people that are agreeing to come and work for us. So we'll have a better statistic for you next quarter. Turnover rate for July was 1.36, August 1.3, September 1.32%. Vacancy rate in July is 30.66%, August 26.67%, and September 28.10%. Workers' compensation, total number of workers' comp notice of accidents. July we had 3, August 4, and September 1. Total number of reportable workers' comp claims to risk management. July 1, August 0, September 0. Total number of lost days away from work due to workers' comp injuries. July 2, August 3, September 0. Total number of employees, number of days on temporary modified duty. July 0, August 1 out of 22, September 1 out of 0. Family medical leave. July, we had 1 new in July, 1 in August, and 2 in September. Ongoing for family medical leave, in July we had 10, August 8, September 6. July for continuous family medical leave, we had 2, August 4, September 2, intermittent. July we had 9, August 5, and September we had 6. Needs and challenges, direct care position. Direct care positions continue to be a priority for New Mexico State Veterans Home. Our abbreviation is NMDOH, instead of NMSVH because of legislation. They have a direct impact on delivery of care and facility census. Contracts with nursing and therapy agencies are increasingly utilized with 24/7 operations. Speech language pathologists, physical therapy assistants, RNs, LPNs, and nurses aides are our needs and challenges. We do contract for all of these services. Talking about a psychiatrist in Mexico, State Veterans Home in the County of Sierra doesn't have a psychiatrist. We've been looking at that. We've had the same difficulties with the firewall. We have the ability to go with the VA, and that again is our issue. It is the whole County of Sierra that we have problems. And I attend a meeting once a month with our local facilities, which I'll talk about in a little bit. We are all looking for psychiatric care.
Is it Ben Archer in your area?
Ben Archer allows for 2 days of psychology and 1 day I found out for psychiatry. So it's really a little bit of help, but they haven't.
I guess we're back to the telemedicine.
Yes.
The reason I'm asking Ben Archer is because Ben Archer, I mean, I know there's bandwidth issues in the entire area,
Correct.
but
Both
Ben
ways.
Archer is actually using telemedicine services with the same New Mexico telemedicine company that UNM and Press is using too. So I think the bandwidth issue can be solved.
The VA is very happy to deal with us. It's that band situation. The Ben Archer has no problem dealing with the VA because basically they are the VA. We're state, and that is our issue.
Well, I think we should have an assessment of our IT capacities then, right? For sure.
So we are working on that. In fact, I will be down there tomorrow,
Tomorrow.
and we will be taking a look at all of that
Wonderful.
bandwidth issue at State Veterans Home.
Thank you, sir.
Okay, because all of these smaller community hospitals have honestly connected via telemedicine services through this local contractor that we're talking about. So I think they've themselves run that problem, so we should be able to as well.
Our hope is to be able to use capital dollars to increase the bandwidth and bring in fiber throughout both facilities, the new and the old ones.
Okay.
Perfect.
Do we have anything in our ICIP request for that, for them?
Not for State Veterans Home at this point, just NMDOH. Yeah. But I think we're going to be able to address their concerns at the Veterans Home.
That's one. Thank you, George. Recruitment and retention team. There were 4 nurse aides, 1 registered nurse, 1 LPN, 3 food servers, 2 recreation workers, and 1 CMA hired during the rapid hire event on July 16, 17. Due to shortage of nursing aides, staff satisfaction survey, PI team was initiated. Staffing ratios have been revisited throughout the facility, ongoing hiring committee, interview process implementing, closely monitoring levels of one-on-ones. Marketing outreach, the facility participates in the Sierra Community Forum monthly. That's one where I deal with all of the facilities in the area. The local hospital and the other nursing home are able to do psychiatric care because they don't have our restraints. Other LTC facilities, we discuss resolve issues related to all health providers, community, share information, work on goals to facilitate the needs of all providers, entities in the community. This has been very rewarding for us. We've always had difficulties with our local the hospital because of emergencies, how they deal with our labs, et cetera, et cetera. Just talking it out once a month, we have been able to solve a certain amount of issues like lost clothing, where did the resident go? So basically, we have a checkout list that says, this is what we're sending with them. They have their own list. They come back, and this is what they brought. We're not losing their dentures and their hearing aids and their cell phones as much as we used to. The labs were wave testing in our facility. So we would drop off our labs and we wouldn't see it for a while. So we knew they have a new hospital in Sierra County. So we have a system where we are dropping off our labs, we take care of it, and we get it back very quickly. So we're very satisfied with this participation in Sierra Community Forum. DBS assisting in marketing efforts, putting New Mexico Veterans Home link back on our website. I talked to General Griego from DBS, and because we are veterans, for some reason, we were dropped off their website when we came to Department of Health. We had a nice discussion. She's gonna have us put back on the website. Articles from the newsletter of The Guardian, VSO taking brochures throughout New Mexico to clients, talking to clients about New Mexico Veterans Home. Director of Nursing, Social Service Director, Admissions Precinct on-site visits for assessments. I'm sending out my staff with potential people that I can admit, and making sure just because it says that I can't admit them on paper, to go over there and make sure, and we find out a different story. Paper and talking to people is not always the best thing. Seeing people in person is going to help us with increased admissions. Community presence. This last month, we had hosted the Alzheimer and Dementia Support Group. We had the community walk in Alzheimer's, and we had little presentations at our facility. Okay, successes. UNM College of Pharmacy participated by students shadowing pharmacy director. WNMU participated in social service interim, received approved food service program transition from DBS to DOH, staff compliant with the DOH online mandatory. Goals: occupy remaining annex rooms that are single rooms with a bathroom and aligned rooms of the main facility becoming one. Questions? Thank you.
Wow, thank you.
I can do that.
Any questions for Administrator Deason? All right, just with time, we will move on to our last presentation from Administrator Tweed, New Mexico Behavioral Health Institute.
I'll try to talk that fast, however, I've had a little bit of a sore throat from my allergies. Okay, I started by, next slide, please. Talking about our services, adult psychiatric division, we have 93 operational beds, which is down to our current HVAC project. We do have adult acute psychiatric hospitalization, treatment, extended psychiatric hospitalization, and there is legal and clinical criteria for admission. At forensic, we have 84 operational beds. They are all court ordered with alleged felony level of crime. I need a treatment to attain competency to proceed with adjudication. And currently, about 50% of our patients have been found to be non-competent, non-restorable. Our CBS division has approximately 1,000 outpatients, and they serve a tri-county areas, San Miguel, Mora, and Guadalupe. They are a certified community mental health center and a core service agency, and they have an assisted living facility that currently only has 14 operational beds. The CARE program is 12 operational beds. It's provides treatment for 13 to 17-year-old adolescent males who have caused sexual harm and have a mental health diagnosis. Our long-term care division has 163 operational beds. Many have a history of psychiatric illness such as dementia. They offer skilled and nursing home care, inpatient and outpatient restorative services. Next slide has our average daily census, and I also included this time our long-term care NPPD, which is averaging about 3.9, and our acuity NPPD is 3.28. Next slide is our outpatient information. We're currently servicing only 958 outpatients only in 3 counties, and I have a breakdown of how many are getting psychiatry, psychotherapy, CCSS, and then rehab. We have our monthly summary for accounts receivable for the quarter. For collected for the quarter was 4.5 mil, uncollectible is 732,000. I do have a 3-year revenue comparison for 17, 18, and 19 FY, and you can see that overall our collection rate did go down for FY19. The reason for that was our drop in census at long-term care, as well as at the care unit, and also we had a high turnover rate in our finance department. We're on the increase, so hopefully this current fiscal year will be improved. The next is our contract costs, and I'm not going to go through a lot of detail. Just this gives you a breakdown of all our medical contracts, psychiatry, nursing, pharmacy, and then all our other professional service contracts, and the total for the quarter is at $617,000. Joint Commission, our last survey was August of 2017. They have to return by August of next year. And we are going to be requesting a deemed survey, which means it's going to be a harder survey than it's been in the past. We are fully accredited. We are surveyed under 3 different standards: hospital, behavioral health, and nursing care. So whenever the survey team comes, they come in like a army. We have to all go all over the facility trying to keep up with them. The care unit will be moving to Zuni, and the ELF residents will be moving to Zia before the next survey due to the ligature mitigation requirement for behavioral health. The current building is so large that they're in that we would never be able to mitigate all those risks. So we've made the decision to swap the populations, which will also allow us to increase our ELF beds. Licensing, the next survey, our annual survey was in June. Our plan of correction was approved. Our window opens in February of next year. We had a complaint survey on July 31st that we actually were cited for actual harm. Thank God it didn't end up being immediate jeopardy. The POC was finally approved. We had another complaint survey on August 27th. That plan of care was approved. These are all at long-term care. The VA survey was conducted on July 15th, but we still don't have the results. Our CARE CYFD survey has been extended to next year. The ELF survey occurred in 2018, and that plan of care was approved. And our CBS survey occurred in 2017 with 0 findings. As a matter of fact, the surveyor said that's the first time that it would happen to her. So I don't know what to do. I've never done. So the next one is our capital projects. I'm not going to go through the whole thing because I tell you what, it's exhausting. We have so many projects going on. Our biggest one, and I'm just going to focus on the projects and processes, our HVAC project. And to give you an example, by next Monday, we should have DHI there to approve our phase 2. We'll be going into phase 3. But in order to even start that project, we're going to have to vacate. We're going to have to move 4 units, I believe. So it's been really exhaustive. It's been difficult. We've had to have psych patients on units that aren't really good for psych patients. But with phase 2 completion, we'll have our 2 admission units done, and we'll be going on to our SPU unit. But we're having to move them to a different unit because the building we have is not fit for them. So that's been a big challenge. I'm praying, hoping that we're going to have that process complete before Joint Commission comes. Our target date is in June, and they're scheduled to come in August. But if they come 2 months early, they're going to be here right in the middle of that project. Our cottage demolition, we're finally going to have our kickoff, I believe, next week, and we're going to be demolishing 4 cottages, Mesa, Vega, El Paso, and Pinon. We're working on the Crestone beam mold remediation, dietary electronic access control, La Planta mold remediation, our life safety plan, ADA assessment that's tied into Joint Commission, sprinkler head replacements at Isleta, Meadows phase 3 is in process, our dietary building HVAC, laundry boiler and HVAC proposal, our APD security fence, Tesuca and Isleta nurses station upgrade, that's also part of our literature. The next slide gave you a little snapshot of our quality performance improvement focus areas, and we will be approving the PI plan that has a lot more detail about our PI. This just is our dashboard for the 5 different divisions. I just picked one indicator for each one. APD is really focusing on elopement prevention. You can see we're not doing so well. That's why we need our fence. Forensic med errors, they're doing fine. CBS suicide risk assessment, they're way above the target. Long-term care falls with major injuries, they're meeting target, and care family participation, they're meeting target. The next slide is a target for 90% for our patient satisfaction, and I have the 3-year breakdown of where we are. We're doing fine everywhere. We just picked one of the questions that we asked for APD care, long-term care, and CBS, and then there's an aggregate satisfaction. We just completed an annual survey at the care unit. We're going to start working on an annual patient satisfaction at forensic next. The next slide gives you our HR information. One of our rec therapists, Esther Lopez, was selected for Employee of the Quarter, so we're really happy about that. We did finally hire a financial admission supervisor, Jerry Martinez. He started 2 weeks ago. We have successfully hired 2 psychologists. It's been years and years since we've hired psychologists. One is for APD and the other one is for forensic. Our direct care vacancy rate is still high at 27.6. For the first quarter, we did hire 44, and we did but dismissed 35, so a little bit of progress. Turnover rate is at 6.7%. Our workers' comp FMLA report, we had 42 notice of accidents. Out of those 42, 20 were related to patient aggression. We have 52 lost days, and we have 61 active FMLA actions. I'm surprised at how little everybody else has, and I can tell you that our techs figured out that they can go get on FMLA and it'll exempt them from overtime. So the majority of that is no overtime, which kills the rest of the employees that do the overtime. And then we did have 3 recruitment events. In July, we hired 18 techs and 3 nurses. August, it was strictly for dietary. We got special permission to have a rapid hire just for dietary because we're at a 50% vacancy rate. And we hired 10 workers, which was almost the majority of our vacancies. And then in September 9th, we hired 16 techs. We're having another one next Monday. Next slide, our needs and challenges. We're losing 3 key people this year. Our executive nurse administrator retiring, director of standards compliance retiring, and our occupational therapist retiring. So that's going to be really cumbersome trying to replace those key positions. Due to our HVAC project, our operational beds at APD decreased to 93. So we've really been struggling to get our court commitments in a timely manner. Due to budget constraints, we are only able to purchase supplies and equipment for direct patient care. So we've had a lot of people complaining about our chairs, our furniture. The next survey is going to be a deemed status survey. I mentioned that earlier, and we're really working hard to get ready for that survey. We're going to have to update our hospital acuity system, which we're in process. We're researching our staffing requirements. My understanding is when you're deemed, you have a separate unit with a door in between the units. You have to have a nurse on every unit. So that's going to make us have, just within the adult psychiatric division, we're probably going to need additional 6 nursing positions just for night shift. ADA compliance nurses station upgrades, I've already talked about that. Of course, we continue to struggle with our tech vacancy rate. As of September 30th, there was a 50% tech vacancy rate. We have, which represents 148.5 tech vacancies out of 297 budgeted positions. Long-term care is at 60% vacancy rate. They're the ones that are struggling the most. NMDOH medication management system is in a critical need of significant technology upgrades. I understand that the pharmacy RFP finally did go through, but yesterday during our IT meeting, I learned that it's going to take 12 to 18 months to implement it, which means that when Joint Commission returns, we're still going to have our current system. So it's really old, cumbersome. We can't really, our network speed is still a mess. So we've had a lot of challenges with our medication management system. And then, as I mentioned before, CVS recently lost 2 psychiatrist providers. We're almost getting ready to lose a 3rd one, so those are our challenges. As far as marketing and outreach, Chief Justice Nakamura and the mental health team of the New Mexico Supreme Court held their monthly meeting at NBHI. That was last month, and they did meet with our APD and forensic division directors. They toured part of our facility and really were focusing on forensic and APD. It was a really great meeting. Both of our psychologists of one of those divisions have been invited next spring to talk to all of the courts throughout New Mexico, so it was a very successful meeting. I attended WIPSHA conference in Phoenix from September 9th through the 13th, presented on the USP 800 requirement that's coming up in December. Our CBS director attended the quarterly behavioral health collaborative meeting. He also attended the Guadalupe County Behavioral Crisis Task Force meeting. Our PR coordinator attended the 17th annual Northeast Transitional Fair at Highlands. Our pharmacy director continues to serve as a New Mexico State Pharmacy representative for the state's pharmacy group purchasing organization. And our pharmacy director is also chairing a network of WIPSHA participants on the challenges of implementing the new USP 800 hazardous drug standards, because many of those administrators were not even aware of that. The next slide is our community presence. Our APD division director met with Highlands to discuss a PsyD program for psychology. Highlands is exploring that, so that will be fantastic. Our pharmacists are regular participants in the UNM Antimicrobial Stewardship ECHO program. I attended a committee for economic development for the city of Las Vegas. Our care residents sponsored a food drive for the soup kitchen in July. One of our pharmacy techs coordinated a drive for our local animal shelter. Our PR coordinator worked with DVR, New Mexico Health Program, for adults and youth, Workforce Solution, and the West Las Vegas and Robertson High School Work Study Program. We had 15 individuals that we sponsored this summer. Dr. Strickert's, one of our psychiatrists, presented to the Help New Mexico group. In September, he also presented to the National Kidney Foundation in Houston, and Louis Trujillo serves as the chairman of the Las Vegas Foundation Advisory Council. I also wanted to just include this slide to let you know how many nursing different programs we work with different universities. We have mentorship to healthcare students from UNM School of Medicine for medicine and psychiatry. We have practicum rotations for nursing students from 8 nursing schools in New Mexico. We have preceptors for students from the PA program and also from the CMP program at St. Joseph's and also New Mexico State University. We're a practicum site for Highlands for social work counseling, psychology, and sociology. And we're an internship program for pharmacy students. Successes and goals, our APD division director is working with WICHE to implement a psychology internship program. Staff development has implemented mandatory training online. That's something that I've been working on for years, and we finally got it done. So people that have computer access can do their annual training online instead of having to go in person. We created our own employee health committee, and we're very active, and they were instrumental in doing our Week of Wellness celebration this year. Our clinical staff continue to work on implementing the suicide risk assessment policy and procedures to make sure we're in compliance with the Joint Commission requirements on suicide risk assessments. And then we're well on our way to implementing policies and procedures to meet the USP 800 requirements in December. We're currently piloting new procedures to meet the new Joint Commission and National Patient Safety Goal on anticoagulation. The Adaptive Equipment Department merged with our Patient Safety and Security Department to enhance surveillance of biomedical equipment. And our Security Department, we increased FTEs to help for them to assist us in prevention of elopements. Inpatient activities during the first quarter, our adult psych rehab services provided activities for 6,342 patients and clients throughout the hospital, along with dietary. They hosted activity on the farm for the 4th of July for community-based services, adult psych, long-term care, and care. And then there's a photo here of Jillian, our program manager for Vogue Services, presenting a plaque to a lady from the hatchery because they constantly provide fish for our farm, so our residents get to go fishing. Outpatient activities, our outpatient clients participated in the Las Vegas Fiestas this year. And in August, they had an award ceremony, so they presented participation awards to recognize hard work for some of the clients. And then they celebrated the end of the summer activities with the picnic at El Porvenir. And then we did have our 3rd annual Week of Wellness. That was our calendar that we celebrated. And we had salsa dancing, we had meditation, we had acupuncture, we had our own farm come and do a farmer's market. So it was really good. We had people from throughout the community that came one day and did some presentations for our staff. We had our medical staff members present on stress. So that's my presentation. Any questions?
Very good. Good work, Francis.
Talk as fast as I could.
All right, there's no questions. We're going to move along due to time. Is there a motion to approve facility administrators' reports as they were presented? Oh, sorry.
I apologize. I think that I need to just say, for purposes of the record, that Sequoia Treatment Center wasn't here today because of an issue requiring the administrator's attention. She requested absence in advance of the meeting, and that her absence has been excused from the meeting today. So moving on to the vote.
So we want the motion to be that you'll accept the administrators' reports, with the exception that SATC will turn in their report late.
Right, and then I guess we'll review it again in January. We'll have reviewed it in advance of the January meeting, and then we will approve it in January.
I'll make a motion of what Eric just said.
Okay.
Is there a second?
Second.
All those that are in favor of passing the motion of accepting the administrators' reports, except Sequoia Adolescent Treatment Centers, which will be reviewed at a later date, please say aye.
Aye.
Nays? Motion passes. At this point, we will move to Program Area 6 financial report by Mr. Shadian.
So I'm actually gonna, since I voted out, I'm actually gonna pass it over to the acting ASD Commission Director to provide support.
Okay, and I will be providing the Facilities Management Division financial report, period ending September 30th. Our projected year-end deficit, not a year-end, is just through September 30th. The first 3 months is actually 6.1 million. It's a deficit. As you can see, for the first, the past 3-4 years, we've finished 16 in a deficit, and then 17 and 18 and 19 in a surplus. FY19 surplus of 1.3, of course, that's unaudited. We're almost to finish our financial statements and our audit before November 1st, which is the statutory deadline. The next slide is actually our Facilities Management Division operating budget. I'm not going to go over this because everybody knows what their operating budget. Of course, this is not our FY20 revenue projection, which is slightly different than what our operating budget is. Our next slide, as you all know, this is all year operating budgets based on our category of expenditures and by revenue streams from general fund all the way to other state funds. That matches our 148,524.9 operating budget for FMD in total. The next slide is our performance measures. I will be giving the fourth quarter and the annual and what we finished at FY19. Percent of eligible third-party revenue collected at all agency facilities. The target was for us to be at greater than or equal to 93%. The fourth quarter was at 76.3%, and overall for FY19 we finished at 83%. The number of significant medication errors per 100 patients, it should be less than or equal to 2.0. The fourth quarter was 0.4, and in total for FY19 was at 2.4. The percent of long-term care residents experiencing one or more falls with major injury, we should, our target was less than or equal to 0.5%. Fourth quarter was at 2.8%, and FY19 total was at 3.9%. And that concludes the Facility Management Division's financial report, and I'll stand for questions if any.
I have a question. I think I know the answer, but can you, just for the state, the rest of the administrators as well as the public record, a brief explanation of the deficit in the first quarter?
The deficit, the majority, as we all know, that we're encountering right now, number one, in FY19, when we first started FY19, we all got a 2% increase in pay, all employees. In the middle of FY19, we also got and we did appropriate placement for nurses and techs and so forth. And that now is being compounded on an annual basis. And then as well as our FY20, everybody got a 4% increase in pay, and so that's what's compounding this issue. So we have had meetings with facilities and working with each facility in trying to reduce, our nursing contracts and so forth. And I'm making sure that I'm analyzing those on a monthly basis. And I have even talked to Francis and so forth. They've done a wonderful job on their end regarding the nursing contract. From what I see, they have been spending like $1 million a year And it's projected probably they'll be spending probably half of that this fiscal year. So you can start seeing some of these things happening, no different than what Shauna mentioned. You know, she's got 2 contracts out there. I haven't even seen an expense out of her nursing contract, so she hasn't been meeting those. And so I'm looking at all these variables. That's what's happening.
I would add to that too, you know, going through the projections, I think also a lot of the finance folks probably are very conservative on the revenue side. So we should probably expect more revenue coming in later as we get more actuals built into the projection over time.
Okay. Any other questions about the financial report? I see none. Is there a motion for approval of the financial report as presented?
Second.
All those in favor of approving the financial report, say aye.
Aye.
I see no nays, it passes. We'll move to approval of policies. I'm going to ask for some help from council. Do we, these approvals of policies have already been presented to us, correct?
Correct.
And do we have to go through each of them or pass them on once?
We can pass them on mass. I would request that I name the policies we're about to vote on. So for Fort Bear, there were 6. There was medication reconciliation, AT08, QA18, role of the laboratory and radiology director, QA19, role of the admissions director, QA20, role of the human resources director, QA21, role of the finance director, and the security camera policy, AD52. Sequoia Adolescent Treatment Center provided 3 policies: high-risk precaution policy, high-risk precautions, policy number 1514. High-risk precautions, order for doctors to fill in, and the high-risk precautions discontinuation order
which is credentialing only, Crystal Little, and then one application for privileges. Mila and I, Shauna left, don't know how to pronounce her last name. Renikin,
Can you spell it?
Reinikainen.
That's it.
That is it.
Okay. As that list presented by Ms. Fields, is there a motion for approval of this list of credentialing?
Motion.
Is there a second? All those in favor of approving this list for credentialing, please say aye.
Aye.
Aye. I see no nays. This.
Oh, he's
Very Is that Dr. Massaro?
Yes, I'm on my cell phone. I can't speak to Skype, and I think there's a delay. But yes, as usual, Michelle did the most important work. Her report was accurate, and I vote yay.
Great. With that, the panel of individuals is approved. We will move on to consideration to amend bylaws. Once again, Council, I will ask for some assistance.
Sure. So I redlined, this seems to be a thing that we're doing lately, modifying the bylaws. So I redlined it and provided it on the policy drive that Odette referenced you to. And there were just minor changes. I took out effective July 1st, 2019 concerning the state veteran zone. But the primary reason why I felt compelled to modify the bylaws is because Deputy Secretary CA was the ASD director. So I'm modifying by hand now, but he was the ASD director, and so the change was to take Charles out as CFO and replace Eric. But now Eric has, congratulations, by the way. So now Eric is deputy secretary, and as I understand through the meeting today, now you're acting ASD. So for the purpose of this motion, you are a member as the chief financial officer, and we're amending it to allow ASD director to be a member of our board. So that's the primary change.
Can I ask a clarification?
Sure.
Just because it's a public record, do we need to refer to Mr. Chenier as acting deputy director? Because we still need approval and appointment by the governor, correct?
Okay.
Yes.
So I will make that.
And that's been, Kathy wanted that to be clear.
Okay. The only other thing, just for your future thinking, is I appreciate the administrators who responded when I noted the paragraph concerning administrators and the nursing director are responsible for the facilities. And I got different responses from you, and so I will be in contact with you to try to work on what the best terminology is. So we're not changing that paragraph. That paragraph has been that way since before I took this job. And so it is my hope that by January, we'll have figured out the proper language to change that so it reflects each facility. It's mostly just the terminology matter. I mean, obviously the administrators are responsible for your facility, and so I'm just trying to find language that represents all facilities. And so I guess at this point,
There's no approval of these amendments at this point then, correct?
That's what we need to vote on. And then I will circulate the modified bylaws and you'll sign and date. as I've indicated the changes. I can circulate my red lines, so you can see where changes were made if you want to refresh your recollection. But I would appreciate after we vote on the bylaws that I will circulate and you will sign in your respective spot. So I have you down here, but I have you as listed as acting. And so we have a quorum. I don't think necessarily you are a member of the board yet, but it really doesn't matter. And you can sign because it really doesn't matter. All right. So I would propose that a member of the board move for the approval of the changes to the bylaws. Do we have anyone who would move?
I can make a motion.
Okay, and then there's a second?
Second.
And so I'll,
And we have to vote.
yes.
Is there any discussion about the amendment to the bylaws? No. I see no discussion, therefore, is there, let's vote to approve the amendments of the bylaws as suggested by council. All those in favor say aye.
Aye.
Aye. I see no nays. The amendments pass. Council, anything further?
I guess when we're moving on to announcements, I have.
Okay, so we'll be moving on to announcements. The next meeting is January 16th, 2020. A reminder, we will also be approving Sequoia Adolescent Treatment Center's report that was absent at this meeting at the subsequent January meeting. Council, you had other announcements?
It's come to my attention that it's best practice to have a resolution on behalf of the board that talks about the Open Meeting Act. Our bylaws pretty much follow the Open Meeting Act requirements, but it's best practice to have a separate document that resolves that we will follow the Open Meeting Act. So I also posted this on the drive where everybody has access. And I'd like to just refresh your recollection to a few points. We're going to have regular meetings quarterly. They'll rotate between the 5 facilities, our Los Lunas Community Center, or other location as determined by the governing board. We're allowed to have special meetings and emergency meetings, and the purpose of special meetings and emergency meetings, there are certain requirements concerning notice. Members of the governing board may participate in any governing board meeting by means of a conference telephone call if they get permission in advance. The governing board may close the meeting to the public if it's subject to the discussion that's exempt from the Open Meetings Act. And so I would, this also, this document needs to be done on an annual basis. So we will do it this session, and then it will be on the agenda in January so that we'll have this document in place for 2020. And so I would request a motion that we have the final paragraph here says, passed and adopted by the New Mexico Department of Health Facilities and Los Lunas Community Program Board on the 17th day of October 2019, and then it only needs to be signed by Dr. Ash. So I need the motion to accept the open meetings resolution and a second. And then we'll vote. Would you like to press the vote?
Sure. Is there a vote to accept the addition of the this documentation of the Open Meetings Act? Is that correct?
Yes.
All of those in favor? I think there was a motion, there was already a second. And is there any discussion? All those in favor of accepting this addition to the this document of the Open Meetings Act, please say aye.
Aye.
Aye. I see no nays. It passes. Our next item is open comment to the public. Are there any comments from the public at this time? I see no comments from the public. This is where I'm going to ask council for assistance in need to go into closed, do you have to go to closed session every time? If
Um,
there is a desire, or please help me here.
sure.
This is the front.
Again, it's on our agenda and, we vote whether we should go into closed meeting or not. So,
So that's easy, we can take a vote there.
right,
If there's, the topics of normal discussion that happen during a closed session will be strategic and long-term business plans of public hospitals, any attorney-client privilege pertaining to threatened litigation, or QA, quality assurance and performance improvement plans protected by HIPAA. Do any administrators feel that we need to move into closed session today? Not necessarily. I do not see any need to go into closed session, so let's take a vote. Do we need to go into closed session today? If the, wait, how do I say this? Is there a need to go into closed session today? All those in favor say aye. If you're listening, all those in favor say nay, or not in favor say nay.
nay,
Good, there's no need to go, that passes, we do not go into closed session.
very good.
At that point, we will adjourn our full governing board session. I apologize for the tardiness of going 30 minutes over. We stand adjourned. Thank you.